Today I'll be presenting about the fatty retina. So this is a child with lipid exudation, telangiectasia at the macular area. So what is the most likely diagnosis? So this is another child with lipid exudation, telangiectasia, aneurysms, as seen in the fluorescein angiogram. So what is the most likely diagnosis? COTS. So another child with saccular aneurysm, telangiectasia, subretinal exudation. What is the most likely diagnosis? Another child with exudative retinal detachment, vasoportal tumor, as you can see here, and telangiectasia. So what is the most likely diagnosis? This is an adult patient with subretinal fluid, bisecting the fovea, lipid exudation, telangiectasia. What is the most likely diagnosis? This is one of our cakish patients with Dr. Suleiman patient with superior temporal telangiectasis, light bulb appearance, telangiectasia with extensive exudative retinal detachment. So what is the most likely diagnosis? So the question is, are they all cause disease? So Coates was the Scottish ophthalmologist who described an idiopathic condition characterized by telangiectatic and aneurysmal blood vessels with intraretinal subretinal exudation. He subdivided his observation into three groups. The first group was massive subretinal exudation with no vascular anomalies. And the second group was massive subretinal exudation with vascular abnormalities. And the third group was eyes with massive subretinal exudation and the flank retinal AV malformation. After that, von Hebel came and he said that the third group of codes is actually a separate entity and later retained as retinal hemangioblastoma, as you know, von Hebel-Lindau syndrome. Then von Leber described a disease similar to that seen by Coates, but without massive subretinal exudation. And this condition was later termed deeper multiple miliary aneurysm. Then Leber, in another paper in 1916, concluded that his observation is actually as an earlier stage of the same disease process described by Coates. Rees in 1955 observed a patient with Leber miliary aneurysm that progressed to the classic Coates disease, which means that Leber miliary aneurysm and Coates disease are the same disease process. Gass in 1968 described idiopathic juxtafoveolar retinal telangiectasia, and this resulted in an extensive detailed classification in 1993. So Coates disease has a spectrum of manifestations. So these conditions are the same disease process. So Leber miliary aneurysm is a mild form of Coates disease. Coates disease is the classic form. Adult-onset Coates disease is the adult form. Macular telangiectasia type 1, when the disease process is limited to the macular area. So regarding the pathogenesis of Coates disease, it is an unhereditary condition. Coates and other authors thought that the etiology of Coates disease is an infection, and they thought that toxoplasmosis might be the underlying cause. Then using anti-inflammatory and anti-infectious agents refuted the early theories of primary infectious or inflammatory etiologies, as patients did not improve on anti-inflammatory and anti-infectious agents. So what happens in Coates disease is degeneration and abnormality of retinal endothelial cells that will result in formation of telangiectasia, saccular fusiform aneurysms, loss of blood retinal barrier, and subsequently intraretinal subretinal exudation, exudative retinal detachment, and sometimes subfoveal nodules. Work in molecular genetics suggests that Coates disease may be a result of a spectrum of related genetic disorders known as retinal hypovasculopathies, which might also include Nuri disease, fever, facioscapulohumeral muscular dystrophy, and osteoporosis pseudoglioma syndrome. All of these conditions share a similar phenotype, and they also related to abnormalities in the Wnt signaling pathway during the retinal angiogenesis. So several reports, including inoculated eyes and animal models, have implicated a deficiency of neurin, which is a retinal protein, in the pathogenesis of cause disease. So when a mutation in NDB gene, which is a Nuri disease pseudoglioma gene, occur, this will lead to deficiency of neurin, and this will also lead to abnormal retinal vasculogenesis. Although fever and cause share certain clinical features, genetically they are not the same. Some people think that cause disease is actually an asymmetric fever, but in reality they share different genetic bases, and cause disease is a distinct ocular condition. Recently, Cox plus disease was discovered to be the result of mutation in CTC1 gene, and it consists of cause disease plus abnormalities of the brain, bones, and gastrointestinal system. It's also known as cerebroretinal microangiopathy with calcifications and cysts, and it is inherited in some recessive manner. Regarding the histopathology of cause disease, as you can see here in the histopathological image, the vascular wall of this blood vessel is thin with loss of endothelial cells and pericytes, a disease process similar to what we see in diabetic patients. That's why diabetic patients, they will have lipid exudation. Other findings in histopathology of cause disease is a gliotic and thickened outer retina over the subretinal fluid. Sometimes you might see pigment-laden macrophages, as you can see here, and the arrow is pointing to pigment-laden macrophages. In advanced cases of cause disease, we might also see intraocular bone formation and calcification, which might also confuse with the diagnosis of retinoblastoma. More recently, it was noted that VEGF immunity activity was found in the subretinal macrophages, detached retina, blood vessels, and aqueous humor of patients with cause disease. And they also noted that with increasing disease severity, there was more VEGF expression inside the eye. These findings support the widely held view that cause disease is a disorder of vascular integrity, and also support the importance of anti-VEGF medications in the treatment of cause disease. So cause disease is a unilateral disease in 95% of cases, and predominantly in young male. So if you see cause disease bilaterally or in a female, you should think about coats-like conditions such as retinitis pigmentosa, parsiplanitis, fever, and other disorders. It usually present in young patients with no racial or ethnic predilection. In the famous series of Shields of 150 consecutive cases, the mean age at diagnosis was 5 years. Some speculate that the disease could be present at birth. So these are different photos for patients with cause disease. The first photo is for a patient with leukocoria, esotropia. The second patient is with xanthocoria. The third patient is for extensive exudative retinal detachment abutting the posterior lens capsule. And the last patient has cholesterol crystals inside the anterior chamber. Typical ophthalmoscopic picture includes subretinal exudation with vascular anomalies in form of sheathing, telangiectasia, tortuosity, aneurysmal dilation, zones of capillary dropout, or maybe occasionally neovascularization. So in the series of Shields of 150 consecutive patients, the most common presenting symptom was decrease in visual acuity in 43% of patients, followed by strabismus and leukocoria. And the most common presenting visual acuity was hand motion to no light perception in 58% of the patients, whereas 42% of the patients presented with counting fingers vision or better. Posterior segment findings included telangiectasia and intraretinal exudations in almost all of the patients, followed by exudative retinal detachment in 81% of the patient. Other findings might include retinal hemorrhage, retinal macrocyst, vasoproliferative tumor, optic disc neovascularization, and retinal neovascularization. The anterior segment was normal in 90% of the patients. Regarding the distribution of the telangiectasia in the Shields paper, she found that half of the patients have their telangiectasia in the far peripheral retina in 51% of the patients, followed by the near peripheral area from the macula to the equator in 30% of the patient. Diffuse involvement was in 18% of the patients, and the macular involvement alone was in only 1% of the patients. And regarding the involved retinal sector, the temporal retina was the most involved part of the retina in 42% of the patients. Inferior retina was affected in 26% of the patients, followed by diffuse involvement in 22% of the patients. These are fundus photographs from the same paper of Shields. As you can see here, sacral aneurysms with telangiectasia without exudation. In this fundus photo, you can see the aneurysms, telangiectasia, as well as hard exudates with foveal scar. This is a photo for retinal macrocyst with retinoschisis, and this is for a patient with Coast disease and inferior vasoproliferative tumor. Other studies have described macular fibrosis in up to 23% of patients, developing in an area of a previous dense exudation and involving the fovea in all cases. So this is a patient with Coast disease. As you can see here, there are vascular abnormalities. This patient received a scattered laser to treat his Coast disease. So after 9 months, the heart exudates start to resolve, but the patient started to form a fibrotic scar. And after 3 years of the follow-up, this patient has almost complete resolution of his heart exudates, but he formed a fibrotic scar at the fovea. Central vision in Coast disease is usually affected by foveal heart exudates, exudative macular detachment, cystoid macular edema. Generally speaking, this disease is slowly progressive. Spontaneous remission is exceptional but has been reported in the literature. Subretinal choroidal neovascularization rarely occurs in the area of lipid deposition, and it was reported in the literature that it responds well to the anti-VEGF agents. Exudative retinal detachment can be highly elevated and seen behind the crystalline lens. Hemorrhagic and non-hemorrhagic retinal macrocyst might occur in an area of a previous cystoid macular edema or as a result of retinoschisis. So this is a patient with extensive exudative retinal detachment abutting the posterior lens capsule. Secondary complications such as iridocyclitis, cataract, neovascular glaucoma that can lead to phthisis bulbi can complicate Coast disease. In Coast disease, glaucoma might occur as a result of two mechanisms. The first one is the neovascular glaucoma, which is the anterior pulling mechanism. The fibrovascular membrane at the angle will contract, then will occlude the angle. So this is one mechanism. The second mechanism is the posterior pushing mechanism, by which the exudative retinal detachment will push the iris, lens diaphragm, and will close the angle, causing angle closure glaucoma. So this is another mechanism by which Coast disease patients will have a glaucoma. Regarding adult onset Coast disease, when compared to the classic Coast disease, which is the juvenile form, it has a smaller area of involvement, slower disease progression, more benign natural course, typically not present with strabismus, and associated with hypercholesterolemia, and in one case series associated with systemic hypertension. In a series of 48 eyes, the mean age of presentation was 47 years. So these are fundus photo for patient with adult-onset cause disease. You can notice the milder manifestations when compared to the classic cause disease. The most recent and widely used staging system was introduced by Shields and Associates in 2001. Other staging systems are not currently used. This staging system consists of 5 stages. So in the first stage, and we have simplified format, you will have telangiectasia alone, this is stage 1. When you have exudation, this is stage 2, which could be extrafoveal or foveal. And the third stage, when you have detachment, and it is simplified with D. Fourth stage, when you have total retinal detachment with the glaucoma. And the fifth stage is the end stage with phthisis bulbi simplified with P. The most prevalent stage is the third stage, representing 69% of Shields series. So this is a patient with stage 2A, as you can see here, telangiectasia, aneurysms that leaks the dye with hard exudates outside the macular area. This is a patient with stage 4 disease with a glaucoma, and you can see the total retinal detachment. This is a patient with stage 3B. As you can see, total retinal detachment involving the macular area. So this is a patient with adult-onset cause disease. As you can see here in the magnified photo, this patient has vascular abnormalities. This patient received a scatter laser for his vascular abnormality. The hard exudates improved, but this patient formed a fibrotic scar at the foveal area. Regarding the differential diagnosis of cause disease, any disease that can produce leukocoria or strabismus can be included in the differential. And the most important condition is retinoblastoma. Shields and Associates reviewed the 150 cases of cause disease, and the diagnosis was correct in 41% of cases. Other cases had a mistaken referral diagnosis, and the most common one was retinoblastoma in 27% of the cases. It's important for all ophthalmologists to differentiate between cause disease and retinoblastoma. As you know, that cause disease presents with older patients when compared to retinoblastoma. It is unilateral in 95% of cases, whereas retinoblastoma is bilateral in 40% of patients. Male is more common cause disease, where in retinoblastoma there is no sex predilection. Retinal vessels are has irregular dilation with telangiectasia, where in retinoblastoma has regular dilation. The vessels can be traced in cause disease, where in retinoblastoma it will dip into the mass, then will disappear. Exudation is a feature of cause disease. Vitreous seeding is a feature of retinoblastoma. Subretinal fluid texture and composition is different between the two conditions. Calcification is a feature of retinoblastoma. Intraocular mass can be seen in fundoscopic exam in endophytic cases of retinoblastoma. Retinoschisis and retinal gliosis are features of cause disease, and in MRI there will be an enhancement of the mass in retinoblastoma. Cause disease can simulate other exudative retinal conditions such as fever, but in fever there will be retinal dragging, unlike the cause disease, positive family history, and bilateral presentation when compared to cause disease. Other conditions that can mimic cause disease are peripheral vasculitis, Eales disease, and facioscapulohumeral muscular dystrophy. We talked about Quadruplex syndrome. The term cause disease should be reserved for cases of idiopathic retinal telangiectasia associated with intraretinal exudation with or without exudative retinal detachment without evidence of vitreoretinal traction. This is the definition that was used in Shields' paper. There are a lot of conditions that can mimic cause disease and can produce COATS-like retinal findings. And ophthalmologists need to differentiate between COATS-like conditions and the classic cause disease. Let's move to the treatment of cause disease. It depends on the stage and severity of the disease, and our aim in the treatment is to obliterate the abnormal blood vessels by different treatment modalities. Mild cases with only retinal telangiectasia can be observed with serial photos. If subretinal fluid or exudation develop, then the intervention is needed. The first and the most important treatment is the ablative therapy in forms of laser or cryotherapy. So we can use FFA guidance to treat. Yellow laser has better absorption. We usually treat the leaking lesions directly with moderate to large size spot size of moderate intensity. There is an important basic concept to understand. For laser to work, it needs a chromophore. And as you know that our neurosensory retina is transparent, so it is a poor chromophore. So for example, in cases of horseshoe tear, you need a direct contact with the underlying RPE, as the RPE has dye, so the laser can be absorbed by the retinal pigment epithelium and will form chorioretinal adhesion. So this is the mechanism in laser retinopexy. Whereas in cause disease, our goal is not to form a chorioretinal adhesion, but our aim is to obliterate the abnormal blood vessels. So the chromophore for us in cause disease is the hemoglobin. So we directly photocoagulate the abnormal blood vessels even in the presence of subretinal fluid. Infrared laser wavelengths have inadequate absorption spectra for intravascular chromophore. For this reason, the argon green laser is preferred over the dyed laser. Scatter photocoagulation to areas of non-perfusion is of unproven value, but could decrease the risk of later neovascularization. Extensive laser might lead to paradoxically increasing the retinal exudation because of the disruption of the blood-retinal barrier. Cryotherapy can be used if the laser is ineffective, or if you have a peripheral lesion with poor dilation, or if you have a lot of subretinal fluid. But compared to laser, cryotherapy has more complications. BDT in combination with intravitreal bevacizumab for adult cause disease was reported in a single case report with apparent success. Intravitreal corticosteroids have been shown to be effective in reducing macular edema and subretinal exudation, but of course cataract and high IOP are the side effects. Intravitreal triamcinolone acetonide has been combined with the cryotherapy and laser photocoagulation in cases of severe exudative detachments. And we have our Kekish experience. There are two papers published by Kekish, one in 2012 and the other one in 2021 by Dr. Nicola Ghazi and colleagues, and Dr. Wael Sakran and his colleagues. And it showed that intravitreal triamcinolone is effective in decreasing subretinal fluid and cause disease. Intravitreal anti-VEGF agents are reported to be effective either alone or in combination with intravitreal triamcinolone acetonide, laser photocoagulation, or cryotherapy. But it's important to note that one of the side effects of anti-VEGF agents is to form vitreous fibrosis and fractional retinal detachment, as reported by Shields and Harry group. Intravitreal anti-VEGF agents are not a definitive treatment, but adjunctive treatment. Should be used with other treatment options. Until now, no data on the long-term consequences of repeated anti-VEGF agents and the treatment of Coast disease in children. So this is a patient who was treated with intravitreal ranibizumab and laser photocoagulation for Coast disease. And you can see here almost complete resolution of the hard exudates, and you can see also the difference in the OCT. Regarding the surgery in Coast disease, it should be the last resort after trying all the other options, or if the other options are ineffective. So eyes with advanced retinal detachment awaiting the crystal lens or those with rheumatogenic component might benefit from the surgical repair. Many surgical techniques have been reported in the literature. So like pulse plana vitrectomy with removal of vitreal and pre-retinal membranes plus endolaser. Or some authors reported doing intentional retinotomies to drain the subretinal fluid followed by the endolaser and intraocular tamponade. But some authors do not advise to do intentional retinotomies because retinal plaques might lead to persistent total combined exudative rheumatogenic retinal detachment as a result of the underlying RPE deficiency. If you have a bullous high exudative retinal detachment, patient might benefit from intraocular infusion, external drainage of subretinal fluid, then application of the cryotherapy. If in the end-stage cases, patient might benefit from inoculation, or if the IP is high, will benefit from transscleral cyclophotocoagulation. So this is a patient with extensive exudative retinal detachment who had fusion line in the anterior chamber, then the surgeon drained the subretinal fluid transsclerally. So this is a patient, Dr. Marcus Ropio. I saw this patient at the beginning of my fellowship. I did laser for him with the triamcinolone. This is the triamcinolone. The lipid exudation is less, but this patient started to develop a tractional membrane. Then with the follow-ups, his disease deteriorated. Then in February 2023, he needed a surgery. Dr. Ropio did the surgery for him. And this is in the second day post-operatively with no tamponade inside the eye. You can see that the retina returned back to its normal position with less subretinal fluid. Let's talk now about the Coats-like retinopathies. In this lecture, I'll shed light on some of the Coats-like conditions, but it's very difficult to cover all of them. One of them is facioscapulohumeral muscular dystrophy. It's an autosomal dominant condition, affects the face, shoulder muscles, and later descends to involve the abdomen and the legs. A variant of Coast disease can affect 50 to 75% of patients. It has bilateral involvement, and as we said before, it's related to abnormalities in Wnt signaling pathway during the retinal angiogenesis, similar to the pathogenesis that has been suggested in Coast disease. So this is a patient with this condition, as you can see in the fundus photos, lipid exudation, aneurysms, and telangiectasia. And as you can see here, this patient has winged scapula due to the atrophy of the shoulder muscles. This is another patient with the same condition with peripheral neovascularization and ischemia. Another condition called Parry-Rhomberg Syndrome. It is a rare craniofacial disorder of unknown etiology characterized by progressive hemifacial atrophy. Some patients might have enophthalmos. As you can see in the upper photo, this patient has facial atrophy and facial asymmetry. And here from this photo, you can see saccular aneurysm with telangiectasia and subretinal exudation. This is a Japanese patient with the same condition with hemifacial atrophy, mild enophthalmos, and his fundus has lipid deposition and abnormal blood vessels. Another condition might be related to Parry-Rhomberg syndrome called linear scleroderma. So scleroderma means thickening of the skin with fibrosis of the underlying tissue. Linear scleroderma is a form of localized scleroderma. It's also known as onchodosapor, which is trauma by assault, because those patients usually have linear fibrosis on the forehead, and it resembles a trauma by assault. Those patients usually have periocular and ocular manifestations, including COTS-like response. So this is a patient who was initially diagnosed with Parry-Rhomberg syndrome, hemifacial atrophy, but he also found to have onchodosapor, which is linear scleroderma, in his forehead, and histopathology confirmed that he has subepithelial fibrosis. In his fundus photograph montage, you can see the extensive lipid exudation nasally with vascular abnormalities, and you can see also clearly in his fluorescein angiogram the light bulb appearance, the abnormal blood vessels, and in his MRI he has vasculitic lesion in the parietal lobe. Another condition, which is, you all know, which is retinal arterial macroaneurysms with supravalvular pulmonic stenosis syndrome, previously known as a FRAM, might present with exudative retinal detachment and telangiectasis, similar to what we see in Coast disease. Another important condition is retinitis pigmentosa. It might present with COTS-like response in 1 to 4% of cases, including autosomal dominant, autosomal recessive, and X-linked forms of retinitis pigmentosa. So retinitis pigmentosa is a rare disease, and COTS-like response is a rare condition in a rare disease. There is a specific retinal dystrophy condition called preserved para-arteriolar RPE retinitis pigmentosa. As you can see here in the autofluorescence, preserved retinal pigment epithelium around the retinal arterioles. And this is usually associated with CRP1 mutations. CRP1 mutations are usually or a common association with COTS-like response retinitis pigmentosa. In fact, some people in the literature think that CRP1 mutation is a risk factor for COTS-like response retinitis pigmentosa. Later on, many reports found that there are patients who present with COTS-like response without CRP1 mutation. Then a new term emerged, which is CRP1 negative COTS-like retinitis pigmentosa. So this is a patient with CRP1 mutation who has superior vascular tumor and cystoid macular edema. Let's talk now about clinical spectrum, genetic associations, and management outcomes of COTS-like exudative retinal vasculopathy and autosomal recessive retinitis pigmentosa. This is a study that was conducted at Cambridge and published in Ophthalmic Genetics. It's considered to be the second largest case series of COTS-like retinitis pigmentosa in the literature. So it was a retrospective review of ophthalmic multimodal imaging, genetic findings, and treatment outcomes for autosomal recessive retinitis pigmentosa patients who developed COTS-like features. Identification of patients included searching in our retinal dystrophy registry of 798 patients. The table will be summarized. So 10 eyes of 6 patients with autosomal recessive retinitis pigmentosa demonstrated inferior temporal peripheral retinal telangiectasis combined with unilateral inferior temporal vasoproliferative tumor in 4 eyes. So 4 eyes out of the 10 eyes had VBT. Bilaterality was in majority of patients, 67% of patients. Exudative retinal detachment developed in 5 eyes, of which 4 eyes had BVT. Ablation of the vasculopathy using retinal laser photocoagulation and/or cryotherapy in 8 eyes allowed exudative retinal detachment on lipid exudation to decrease in 7 eyes despite incomplete vasculopathy regression. So laser or cryotherapy are effective. One patient received intravitreal triamcinolone acetonide, but it failed to regress the subretinal fluid. Again, we cannot generalize our finding based on a single case. It might be beneficial if it tried on more patients. Observation in one eye caused increase of exudation. It means that this disease is progressive if not treated. 6 mutations, including 3 novel mutations, were found in CRP1, CNGB1, RPGR, and TULP1. So these are fundus photographs of our study patients. The upper 3 photos for a patient with exudative retinal detachment, and inferiorly he had a vasoproliferative tumor. As you can see in the fluorescein angiogram, the leakage of the dye and the retinaloid pooling at the foveal area. The 3 photos in the bottom for another patient with the TULP1 mutation who has aneurysmal dilation, telangiectasia that leaks the dye. The upper 3 photos for another patient with extensive lipid deposition, exudative retinal detachment, vasoproliferative tumor infratemporally. This patient received multiple sessions of ablative therapy in terms of laser photocoagulation. After that, he received the triamcinolone acetonide injection, as you can see here in the fundus photo, but the triamcinolone acetonide did not lead to regression of the subretinal fluid. The photos in the bottom for another patient with inferior lipid exudation and exudative retinal detachment, as well as telangiectasias, as you can see in the fluorescein angiogram. This is a patient with CRP1 mutation. You can see in the autofluorescence photo the typical preserved para-arteriolar retinal pigment epithelium. And in the right eye of this patient, you can see the sheath telangiectasia, which indicates inactive telangiectasis. And behind the lashes, but not shown here in the photo, an area of active telangiectasia with red color. In the other eye of the same patient, he has an inferior vasoproliferative tumor with tractional retinal detachment extending from the inferior retina to the optic disc. This patient received laser photocoagulation, and after receiving the laser photocoagulation, his TRD stabilized. This is after 1 year. So his TRD stabilized, the subretinal fluid resolved, as well as the lipid exudation. So the question is, how does COATS-like response happen in retinitis pigmentosa? It's not fully understood, but there are 2 theories. The first one is accumulation of toxic materials from photoreceptor and RPE degeneration that may induce a vasodilatory response and a chronic retinal ischemia from retinal vascular attenuation. The second theory is a chronic microvascular leakage followed by secondary inferior retinal detachment with subsequent retinal hypoxia because of separation of the choroid and later development of telangiectatic abnormalities. As you observed in our series, all of the vascular abnormalities were in the inferior quadrant of the eye, and exudative retinal detachment propensity for the inferior retina is due to the gravitational accumulation of a fluid from long-standing vascular leakage. So in conclusion, COATS-like features in autosomal recessive retinitis pigmentosa range from retinal telangiectasis to vasoproliferative tumor with extensive exudative retinal detachment and occur predominantly in infratemporal retinal periphery. In addition to their classic association with CRP1 mutations, other genes are implicated. For this reason, we should rethink about CRP1 as a risk factor for cause-like response in retinitis pigmentosa, as there are other genes that were implicated. To the best of our knowledge, this is the first report describing CNGB1 mutations in cause-like retinitis pigmentosa. Awareness of the vasculopathy spectrum is important, and timely ablation of the vasculopathy with long-term monitoring is recommended to prevent additional visual loss in retinitis pigmentosa patients. This is the end of the lecture, and thank you.